Thanks, Rajan. Okay, so from Canada to, which I affectionately call the Australia of the North, back to Australian general practice now. So what I thought that I would do is a little bit of an introduction to some of the other talks that are going to be coming a little bit later on today, is take you through a little bit of a journey that we've been on over the last couple of years about how we can use data to optimise antimicrobial prescribing and stewardship in general practice. So as a little bit of a context, the Olympics is on next year, and I don't know about everybody else, but in my house, everybody is sports mad. They're watching the sports all the time. And we always want Australia to win. But there's just some competitions that you shouldn't try to win at. And we do know that compared to Europe, other European countries and Canada, Australia is quite a high prescriber of antibiotics. So to give it a little bit of an example of that, we know that from our pharmaceutical benefits scheme data that back in 2017, about 41.5% of all Australians had at least one antimicrobial prescription that was dispensed by a pharmacist. And we know from our NPS Medicine Insight data sets and the now unfortunately defunded Beach data set that a high proportion of these are for upper respiratory tract infections that wouldn't necessarily need antibiotic for their treatment. So there's been increasing interest in antimicrobial stewardship strategies in the general practice space as a result of that, because we know, as Noah presented, that the vast majority of antibiotic prescriptions do occur in the community and outside the hospital. But what we do also know is that antimicrobial stewardship strategies in hospitals in Australia have been effective, and they actually form an important part of accreditation. And so this has also led to, well, what is the next step? How do we move out of the hospital walls into the community to have a ongoing antimicrobial stewardship strategy? And it's interesting that there's been a talk about this for a really, really long time, but talk hasn't necessarily translated to a lot of action. So back in 1999, which is 20 years ago now, there was an advisory committee report to government on the threat of antibiotic resistance that covered both animal and human health. But 14 years later, when we were getting the report on the progress of the different strategies that were recommended, the quotes that stand out the most are that it was clear that most of the recommendations have been minimally implemented, and unfortunately barely any of the 22 recommendations have been implemented, yet they remain just as relevant to finding a solution in 2013 as they were in 1999. So 6 years after that, the government responded to that report. And a key thing for us working in the general practice space is that the Senate committee recommended that the Department of Health investigate additional mechanisms to improve antibiotic stewardship in general practice, and the government agreed. So the next thing is, well, what do we do to move it forward so that in another 6 years or 14 years, we're not still spinning our wheels in this space? So, as I mentioned before, I'm a general practitioner. I would say it's quite fair to say that until I started working with NCAS a couple of years ago, I certainly wouldn't have said that I had a special interest in infectious diseases nor antibiotic prescribing and audit. And in that, I think that I'm very close to most of my colleagues who are busy seeing patients. And I think that the policy context of what is happening in the general practice space is really important and does have implication when we're thinking about antimicrobial strategies that we can be looking to design and to implement. And there's a few things that are really important to consider. So first is the fee-for-service model of general practice. So the vast majority of GPs work as contractors. If we're not seeing a patient face-to-face in our room, then we are not generating income. And so for some, this can be a perverse incentive to keep on seeing more and more patients, and possibly contributing to some of the high volume practices that we saw in the last presentation. We also have new policies and practice incentive payments for quality improvement that came in just in August this year. And you may think, well, this is an important driver for potentially changing practice, but you'll notice it says practice incentive payment. So those payments will actually go to the people that own the practice. So whether or not that actually makes its way down to the GPs that are expected to facilitate this quality improvement is another point. We also have a new National Primary Care Data Asset Plan. So there's going to be data flying around from general practices to primary health networks to the Australian Institute of Health and Welfare. And there's concerns at general practice level about the implications of how this data is going to be used to guide policy and payments, and whether there's going to be carrots or whether there's only going to be sticks. So general practice has been using data for quality improvement activities for a really long time. We've had audit tools available at the general practice setting to facilitate things like quality improvement, to look at our prescribing and the like. We've had places like NPS Medicine Insight that provided some academic detailing for quality improvement. We've also had the Improvement Foundation that helped to facilitate that as well. But those are really expensive programs, and they don't often occur over a longer period of time to facilitate improvement and to allow people to track how they're going over time. So the lack of a longitudinal program is a significant issue. And of course, so is a lack of use. Which brings us to the good old knowledge to practice gap, the evidence to practice gap, and how we can look at using data in a way that's acceptable to general practice to help them to optimise antibiotic prescribing, to get off the winner's podium when it comes to high volumes of antibiotic prescribing. And there's lots of different ways you can think about how we can design these different interventions and how we can evaluate them and monitor them over time. And one of the commonly used frameworks is the knowledge to action framework, where we can look at all the data, we can look at what's happening in Canada and the UK, where a lot of work's being done. And we can look and see, well, what can we do to adapt some of that knowledge to our local context and work with our colleagues in general practice to design and implement these interventions. And of course, there's lots of different theories and frameworks that then can map to different stages of the action cycle. And we've seen, once again, the presentation beforehand, that the clinical performance feedback intervention theory is just one such one that can be used. Okay, so before I go and tell you what we've been doing in this space, I just want to introduce the team. And really, this is what's made this project really fun, is that we're able to work as a team of general practitioners, microbiologists, infectious disease physicians, colleagues from our primary health network, health informaticians and computer scientists, and those with an interest in implementation science to build a program of work together. So over the last couple of years, we've undertaken a number of different studies that are bringing us to what we're calling our Guidance GP program of work, which is currently being piloted in 3 general practices here in Melbourne. And what we've been really interested in doing is exploring, how do GPs use their electronic medical record and guidelines to make antibiotic prescriptions and decisions? How is the best way to audit antibiotic prescribing, and how can we make it easier for GPs to access appropriate guidelines to help with their antibiotic prescribing in practice as well? So I'm not going to go through all of these today, but I'm just going to pick up on a few things with a focus on the GP NAPS and our simulation study. So GP NAPS stands for General Practice National Antimicrobial Prescribing Survey. So once again, another mouthful, and hence the acronym. And what we did was we undertook a survey or an audit of 11 practices. So I saw Robin before, who got to travel all across the eastern seaboard, visiting general practices and auditing the records of 50 patients that had received an antibiotic. So there was 572 prescriptions in total because some people got more than one. And then there was different assessments looking at compliance with guidelines and appropriateness of prescribing. And when we couldn't work it out because we couldn't, even with Robin having full access to the electronic medical record, work out what some of the prescriptions for, we tried to work it out by having a multidisciplinary panel discussion. So the aim of the GP NAPS was to look at, can we take a methodology that had proved really successful in the hospital environment, tweak it to make it appropriate for general practice, but also use it as a little bit of an exploratory exercise, because we knew really even at the beginning that Robin wasn't going to be able to travel to every general practice in Australia, sadly, to be able to do these audits. And the reality is that in a hospital, if you've got pharmacists working there, you can kind of say one day you guys are doing the NAPS. But in general practice, where there really isn't any support for audit, and perhaps people aren't adequately trained to be able to undertake the assessments, this was always going to be more of an exploratory study to work out how we could make the NAPS work at scale in general practice. So you can see on the screen the type of information that we collected, but we also collected, or I should say Robin did, where in the medical record she could find the information that we needed to be able to do the compliance and appropriateness assessments. So following the data collection and those assessments being done, the general practices were provided with customised reports, and then we fed it back both in a written report but also through webinars where we had a panel that was available to discuss the results. And I think the most interesting part of this was that it was a really active discussion with lots of shared learning. So I think not only were the GPs able to learn from pharmacists that specialised in AMS and infectious diseases physicians, I think that there was a lot of shared learning from both directions about the kinds of challenges that GPs were dealing with, just how bad some of those antibiotics really tasted, and trying to discuss some of the issues and maybe preconceptions about some of the antibiotics and why they were being used. And as part of this, we were able to also collect some information about what the GPs thought about the audit and the contents and the structure. So what did we report? We reported compliance with guidelines, both at a practice level and with practices overall. And what we did find was that the majority of prescriptions were not compliant with therapeutic guidelines, which is our nationally endorsed guideline. But what we also reported back was appropriateness. And in fact, this was a lot more acceptable to GPs than compliance, and a lot more acceptable as well to volume, because GPs in a way don't care how much they prescribe. They care about whether or not it's going to treat the person's condition. And so the appropriateness really spoke to them, and they felt that that was a much more acceptable and helpful measure to them. So in terms of what data we collected, just to touch on a couple of key things, there was a balance between understanding what was happening at the practice level and some interest in getting information at the individual prescriber level as well. A little bit of a tension there, because some higher prescribers might not want to have that level of information. So there was a bit of balance there in terms of what we provided. And because we were only auditing a small amount at each practice, it really wasn't appropriate to provide it at an individual level because the numbers were so small. I think that what we also found was that there were significant issues around some of the way that the prescribing software was set up, with automatic repeats coming up as defaults for many antibiotics, so that if people did fill those, they would often get double the duration or more than they really needed, or else just have that spare packet sitting on the cupboard in case they needed it later on. But interestingly, the webinar and the feedback was really helpful in getting people to reflect on their performance, how they might, because of some of the feedback they got, that using the guidelines more might be a really great thing for them to do, and how they could change some of the setup of their EMRs at the practice level to fix some of the issues that were identified. And finally, another really important one was that general practice GPs receive for free in their EMR MIMS, which is basically product information for different antibiotics, which suggests different duration and indications for the antibiotics compared to what the latest evidence-based guidelines suggest. So really we're asking GPs to be compliant with guidelines that they don't have that freely accessible to them. And so that's a major issue that we need to address. So what did we decide or find by the end of this? Well, we found that we needed to get some improved indication documentation in the EMR. We needed to look at ways that we could increase access to guidelines, perhaps by embedding them into the electronic medical record. We needed to consider how we could deliver audit and feedback at scale. And then we also needed to think about what happened when we weren't giving audit and feedback and doing webinars. We need to think about quality improvement support in the practices moving forward. So after that, we co-designed a clinical decision support tool that did embed some guidelines within the electronic medical record. And then we conducted a simulation study to explore its usability and required design features moving forward. So just to show you what that looks like, this is a picture of best practice, which is one of the 2 most commonly used electronic medical record systems in Australia. And what you can see here is a little button for therapeutic guidelines that the GP could type in the reason for prescribing here, and it would map to a curated list of general practice indications, and they could click on that, or they could also access it on the main page of their electronic medical record as well. When they clicked on that, it went straight through to the relevant guidelines page, and we also created a pane with some additional patient information and relevant resources for GPs to provide to their patients. So to test this out, we recruited 8 GPs. We introduced them to the tool. They participated in 2 simulated consultations. One was a quite complicated case of a person with recurrent urinary tract infections with a previous antibiotic adverse drug reaction and resistance that really probably did need the guidelines to work out what to do. And the second was an 18-year-old whose mum said she should get antibiotics for her sore throat. So a common reason for people coming into general practice. After those consultations, we got them to fill in some usability questionnaires, and then they participated in a think aloud interview and a semi-structured interview, which we thematically analysed. So this was our sim lab, and basically we were able to videotape the consultations and also record what was happening on the screen of the EMR. And the GPs had access to everything that they would expect to have access to in their own consultation room. So we had a bit of a mixture of GPs. We had 3 that were trained outside of Australia and so would have had less exposure to our therapeutic guidelines. And they ranged in experience from general practice registrars to those that have been in practice for at least 2 decades. So what we found is that the GPs thought that our consultations were realistic and representative of the types of consultations that they saw in practice. And 7 out of 8 of them found that were highly satisfied with the tool and indicated that it was of high usability. And interestingly, the person that did it really hated guidelines. So it's hard to tell whether they didn't like our tool or they didn't like it just because it was a guideline. So some of the key design features were that the GPs liked accessing the clinical decision support from multiple screens as it assisted them with their clinical workflow. They liked the therapeutic guidelines logo. So this GP said it's like the Nike tick or the golden arches. If you see it there, you like on clicking on that. So that was really important. And then integrating it actually within the EMR rather than having it on a separate web page was really important in facilitating access to guidelines and patient resources and was seen to save time. So this GP was saying, well, I open all these different websites, Health Pathways, Australian Sexual Health, RACGP, therapeutic guidelines. They have to close them to get to where they need to go. If they had the CDS tool in the consultation, it would just all be there. So how did it impact on the consultations? Well, the GP said it assisted with their clinical decision-making and helped to inform appropriate prescribing in a timely manner, both as a learning tool more generally and really showing them alternatives that they might not have otherwise considered unless they had opened the guideline. The more experienced GPs thought that the tool would be of increased benefit to those who are less experienced or not familiar with therapeutic guidelines. And so this GP said, well, I come from a generation where I've learned the proper use of antibiotics, so I think it's unlikely that I'd use this. Interestingly, the antibiotic prescribing decision that this GP made were definitely not compliant with therapeutic guidelines. And so this is where we've got this issue of some of the findings that have been presented earlier with very experienced GPs being high prescribers and thinking they don't maybe need guidelines when maybe they're the ones that need them the most. Demonstrating the guidelines was also helpful to convince patients when antibiotics were not necessary, so that using it as ammunition to get out of consultations without prescribing unnecessary antibiotics. And that patient information section provided relevant evidence-based information for patients, which was also helpful in enhancing communication. So for example, here, this person didn't think the tool would make much difference in their clinical decision, but it would 100% help in reassuring the patient, giving them relevant tools for information to go home to read. And similarly here, this is reinforcement again. Here are the guidelines. This is what I'm giving you. This is where it fits in. Here's some extra information about the use of these. So as a result of those consultations, we found or thought that our tool was acceptable, had some high usability, and that the people that even didn't regularly use guidelines still found value in accessing the tool for the patient information component. And so, of course, now we need to think about how would this work in the real world. Which brings us to our next stage, which is our Guidance GP program, which is currently running in 3 general practices in Melbourne. And we're just at the point where our baseline GP NAPS audit is almost complete. And this has evolved from a paper-based tool to a tool now that extracts data from the electronic medical record. And if a GP doesn't say why they prescribe that antibiotic, they get a little pop-up that asks them that just says, look, you've just prescribed an antibiotic, can you just let us know for the purposes of this activity why you've done that? And so we'll really be able to be in much better position to do those compliance and appropriateness assessments and build a data set of prescribing over time and link this to ongoing continuing professional development points. We're working with electronic medical record vendors and therapeutic guidelines about how we can maybe permanently embed therapeutic guidelines within the electronic medical records so that GPs have enhanced access to this. Because it's one thing to say that GPs aren't compliant with guidelines, but then if they don't have access to them, it's a problem. We're working with our primary health network who'll be providing quality improvement support on the ground with GPs. So once they've seen their feedback from the GP NAPS, they'll be able to make some decisions about what they want to focus on that is relevant for them in their practice, in their context. And Ruby's going to talk a little bit later on about shared decision-making. So how do we also provide information that will help in that conversation between GPs and patients to make, again, those appropriate decisions about prescribing. So we're looking forward to learning a lot through this process. We'll have electronic data, we'll have qualitative data, and we're hoping in the end to be able to develop something that can be used through general practice at scale. And the last thing I just wanted to finish up with is the Nothing About Us Without Us movement. So this started in the disability movement, where a lot of work was being done about services and research about people with disabilities, but they actually weren't involving anybody with a disability in the work. And I think it's coming back and closing the loop with how I started this talk about the changes in general practice policy, the different stresses that general practice is under at the moment, some of the concerns and potentially fears about the way that general practice data is going to be used, to develop a program that's going to be acceptable, feasible, implementable, really does need to involve the end users all of the way along the development and implementation. And I think that that's something that has been something that's been really important to us as we've developed this program of work. So I will stop there, and I'm happy to take any questions, and then we're going to move on to, I think, talking a little bit about what's happening in the rural setting in terms of antibiotic prescribing. I feel a bit silly saying anybody want to ask me a question, but I will. Yeah, what if we